So this morning's session is on congenital heart disease. Um, you need to have a fairly good understanding of congenital heart disease because occasionally you're going to get adults coming to the lab with congenital heart disease repaired. Occasionally you're going to get unrepaired congenital heart disease, but you should be able to recognize the basic ones. And then if you're doing pediatric echo, then from time to time you're going to see the unrepaired congenital heart disease. So we're going to look at the definition, try and classify them as best as we can, and then look at how to identify these congenital heart defect on the echo using two-dimensional color continuous wave Doppler. We'll also discuss some of the signs and symptoms and how you make the diagnosis. All right. So some background information. When we say congenital heart defect, congenital means something you were born with. So it's a heart defect that the individual was born with. So it's a defect in the structure of the heart and great vessels presenting at birth. So defect in the great vessels is also lumped into congenital heart defect. It occurs in about 9 in 1,000 births. So it is not uncommon. And a lot of time if the fetus have any significant congenital heart defect, that can lead to stillbirth or earlier death of the fetus. Right. So if the defect is multiple and not if it's not consistent with living outside of the womb, then the baby will die. So it's fairly common, 9 in 1,000 births. I used the International Heart Surgery nomenclature to classify it, but I'm not sure if it's the best classification system. With this classification system, they look at the defects that are hypoplastic. And when we say hypoplastic or hypoplasia, that means it did not develop fully. So it's an underdevelopment of a structure. So if we look at the defects related to underdevelopment of the right and left ventricle, under that comes the hypoplastic left heart and hypoplastic right heart. So therefore, it's going to be smaller than normal. Okay, so when you see hypoplastic, it means small. Hyper mean increase. So, so as we mentioned, under hypoplasia, we have the hypoplastic left heart, and under that, so the left heart did not develop properly, and under that you have PDA. Okay, so let's try and work. If the left heart did not develop properly, so let's think about it. We have to think about it. If the left heart did not develop properly, the function of the left heart is to fill with blood and then pump blood into the aorta, because the aorta basically supply the whole body with blood. So if you have a hypoplastic left heart, the left ventricle is small, you have to get blood into the aorta some which way. So these patients with hypoplastic left heart, they're going to have a PDA. Okay, PDA is necessary for survival. So the PDA is going to connect the pulmonary circuit to the aorta, and that is how they get blood into the aorta. So the blood is going to flow into the right atrium, right ventricle, through the right ventricle flow tract, into the pulmonary trunk, and then via the PDA into the aorta. So that is how these individuals can survive or will survive. So if you were to close off the PDA, they wouldn't survive. So hypoplastic left heart, if they have significant hypoplastic left heart, they will also have a PDA. It's necessary for survival. And then someone with an hypoplastic right heart, so the right heart is very tiny, almost non-functional. So these individuals also need a PDA and a PFO, okay? Because you have to get the blood to the left side. So if they have a PFO, then you can have blood flowing from the right atrium across the PFO into the left atrium so they can get blood across to the left side. So these are just some of the things. So you can sit down and analyze some of these congenital heart defects and figure out what it's going to take for these individuals to survive. So those are the hypoplastic lesions. Then the obstructive defects or obstructive lesions. So the valves can become obstructed. The arteries or veins can be narrowed or blocked. So pulmonic stenosis, so you can born with a pulmonic stenosis. The pulmonary valve is very narrow, so you can born with pulmonic stenosis. The pulmonic vein, you can have what we call pulmonary atresia, where the valve did not develop properly and it doesn't open well, or you can have just pulmonic stenosis. Individuals can also born with aortic stenosis, not very common, but they can. Coarctation of the aorta, so that's a narrowing of the aorta, usually at where you have the left subclavian of artery comes off, or we talk about a ligamentum arteriosus right at that area. So coarctation of the aorta is an obstruction defect. Bicuspid aortic valve, one of the most common congenital heart defect. And then subaortic stenosis, you have a membrane just below the aortic valve, usually in the left ventricular flow tract. And then we talk about septal defects now. So you can have ventricular septal defect, which is the most common congenital heart defect, and then atrial septal defect. So those are septal defects. Then the cyanotic defects, the individual is bluish gray. There's a bluish gray discoloration of the skin, and the congenital defects that can give you this cyanotic defect is persistent truncus arteriosus, total anomalous pulmonary venous connection. So remember, the pulmonary veins normally drain into the left atrium. In total anomalous pulmonary venous connection, the pulmonary veins drain into the right side. So the blood that's going to get to the left side is going to be venous. It's going to be mixed with the venous circulation. So that's why they will have this bluish gray discoloration. Tetralogy of Fallot, we're going to go into that in detail, but it's a congenital, a cyanotic defect. Patient can present with cyanosis. Then transposition of the great vessels, where the great vessels switch. And then tricuspid atresia, where the tricuspid valve is almost non-existent. So those are some of the congenital defects that we're going to discuss. And, that's one of the nomenclature. I mean, there are other um, way you can classify congenital heart defects. You have to be familiar with the image orientation. Okay, there's a congenital convention where the atria are on top, and you should practice that type of imaging when you're looking for congenital heart defect. So with the congenital convention, the atria are on top and the ventricles are on the bottom. The left sided structures are on the viewer's right side. Okay, so that is the congenital convention. So you need to know that. Again, we always stress how you're going to decide which is left and right side. You can identify the right ventricle if you identify the lower position of the tricuspid valve in the ventricle. So that will tell you that it's the right side. If the AV valve is lower in the ventricle, then that's the right ventricle. So that's a very important point, and you should always remember it. All right, so we're going to start with atrial septal defect, ASD. So there's an opening in the interatrial septum. Okay, this occurs in about 1 in 1,500 live births, so it is rare. It is fairly common. So atrial septal defect is just an opening in the atrial septum, and it's very common. 1 in 1,500 live births. PFO, remember what PFO is, a patent foraminal valley. The foraminal valley is right, it's a potential closure of the atrial septum. So that can open from time to time, especially if you increase the pressure on the right side. You can open the PFO right at what we call the fossa ovalis in the atrium. That can open by increasing the pressure in the right atrium. PFO occurs in about 10 to 20% of adults, and that is because you have a potential closure. It's not an anatomical closure, so you can open that from time to time. If you were to draw, so in the atrial septum, when the baby borns, the atrial septum, one portion comes down like that, and then the second portion like that. So because it overlap, there's a closure, but it is not an anatomical closure. So just imagine if you increase the force in this direction, if you increase the pressure right here, you can open this little defect, right, or this little passage here. You can open this passage. And that is why it is so common in adults. 10 to 20% of adults have a patent foraminal valley. Okay? And it occurs right in what we call the fossa ovalis. So that's a potential area for you to get mixture of blood from the right atrium and the left atrium. And not only mixture of blood, but you can also have clots moving from the right side to the left side and cause strokes and other arterial obstruction. So ASD accounts for about 30 to 40% of all congenital heart defects in adults. Okay? So it's fairly common, and there are different types. There are different types of ASD. Okay, so Again, this is your so-called normal heart. This is the right atrium right there. Left atrium is over there. And your atrial septum is right here. Okay? It divides the right atrium from the left atrium, which is right there. So if there's any communication between the left atrium and right atrium, okay, then that's what we call it ASD. So, as mentioned before, there are different types of ASD, and this you need to be aware of this. So if the ASD is right here in this location, so there's the superior vena cava, right up here. Sorry, the sinus venosus defect. So just in this location, we talk about the sinus venosa defect. Okay, your superior vena cava is right here. So this defect is way up. Okay, in the septum. Okay, so it's an upper sinus venosus defect, which is it's rare. So it's not the most common type of ASD. All right, your superior vena cava is right there, and this defect is way up there. So this is your sinus venosa defect, sinus venosa defect, and then you can have this is your inferior vena cava right here. This is the atrial septum right there. All of this is the atrial septum. So number 2 is the lower sinus venosa defect. So this is close to the inferior vena cava. So the lower sinus venosus defect close to the inferior vena cava, and the upper is close to the superior vena cava. So these are not very common. The most common is the secundum defect, which occurs close to where you have the fossa ovalis. The ostium secundum defect. This is the most common. Okay? And then number 4, if it involves the coronary sinus, we talk about the unroofing of the coronary sinus. That's number 4. Okay? Unroofing of the coronary sinus. And then number 5 is very important because number 5 is the ostium primum defect. The importance of the ostium primum defect is that the ostium primum defect is one of the conditions of the endocardial cushion defect. It's actually a partial endocardial cushion defect. So it is a little bit more severe than the others. Okay, it occurs in the lowest portion of the atrial septum, right where you have the AV valves. And a lot of time the AV valves are going to be affected. You can have what we call a cleft mitral leaflet with mitral regurgitation. Okay, so ostium primum ASD is actually a partial endocardial cushion defect. And a lot of these individuals, if you look at the AV valve, the left and the right AV valve is in the same plane. Remember, we said that one way to distinguish the right ventricle from the left ventricle is the lowermost position of the AV valve, tricuspid valve. But if you have partial endocardial cushion defect, or if you have endocardial cushion defect, the valves are going to be on the same plane. So the ostium primum defect, which is lowermost in the atrial septum, is actually a partial endocardial cushion defect. So these are the more common ones. The ostium secundum, the most common one. Ostium primum, which is lowermost in the septum and is usually a part of endocardial cushion defect. And then the sinus venosus, you can have the upper and the lower. Okay, So as we said, the ostium secundum defect is the most common type. It occurs in about 6 to 10% of all congenital heart defect. And some of these patients may have mitral valve prolapse. 10 to 20% may have mitral valve prolapse. There's a condition we call the Lutem-Backus syndrome, where the patient have mitral stenosis. So they have mitral stenosis. So in that situation, they're going to have a lot of blood flow across the septal defect from the left atrium to the right atrium because of the mitral stenosis. And this is what we call the Lutem-Backus syndrome. You're going to have a lot of blood flowing into the right atrium and right ventricle. So as a result of that, you're going to get right heart volume overload. So you're going to get a lot of blood flow into the right heart, the right atrium and right ventricle. And hence you're going to get increased pulmonary blood flow, and the patient can develop pulmonary hypertension. So this can become a significant problem if it is not addressed and not recognized. All right, so the T, you can, sometimes it is not readily apparent on your transthoracic echo, and you can use your transesophageal echo to identify the defect, especially if you're going to do closure. If you're going to do closure, you can use a T, transesophageal echo method to guide your delivery and placement of the device to close it, because we can close that defect by just going through the groin and put the device across the septum and close it. You can use your T, transesophageal echo, to guide the procedure. So again, you can use the T or the transthoracic echo to make your diagnosis. If you inject normal saline into the antecubital vein, you may see what we call a positive or a negative contrast. And we have shown this before. So if you inject your normal saline in one of the big veins, the antecubital veins, that's one at the right where the forearm meets the arm. If you inject agitated normal saline, you're going to opacify the right side, right atrium, and right ventricle. And if there is a defect, then you can see the contrast flowing from the right atrium into the left atrium. And that will clinch the diagnosis. A negative contrast doesn't mean that the study is negative. It means that because the pressure in the left atrium is so great, so you're not going to get bubbles going across the septum from the right atrium into the right ventricle, but the blood that's flowing into the left atrium going to move the bubbles in that area, move the bubbles from that area. So you get an area which is devoid of bubble, and that's what we call a negative contrast. You can also use your color flow to show that there is a flow from the left to the right across the shunt. And you guys should be familiar with the shunt flow, how to calculate the magnitude of the shunt flow. If it's not done properly, it is fraught with tremendous errors, because if you measuring the diameter of either the left ventricular flow tract or the right ventricular flow tract, and you're going to square that, you're going to square the error if the measurement is not accurate. So the shunt flow magnitude is just the pulmonary the pulmonary flow divided by the systemic flow. And as we had mentioned before, flow is cross-sectional area times the TVR. So if you're talking about the pulmonary flow, is the cross-sectional area across the right ventricular flow tract. So the area is pi r squared. We can get the diameter of the right ventricular flow tract, parasternal short axis at the level of the aorta. We get the diameter, we divide the diameter by 2, and that's the radius, and we square it. Pi r squared, that's the area. And then the TVI we're talking about is a TVI across the right ventricular flow tract. And then for the systemic flow, it's across the left ventricular flow tract. You do the same thing. Again, the area of the left ventricular flow tract, pi r squared. The diameter is the left ventricular flow tract diameter. We divide it by 2 to get the radius. Pi r squared gives us the area, and then we multiply it by the TVI to get the systemic flow. The TVI is the TVI of the left ventricular flow tract. Okay. So when you get a septal defect, you should go over these methods, and because and you have to try and do it accurate. Just don't do it for doing it sake. Accuracy is important. So we usually talk about it is time to operate, close the defect if the pulmonary to systemic flow ratio is 1.5 or greater, especially if the patient is symptomatic. If the patient is symptomatic, then all bets are off. You should close the defect. Again, as we mentioned, the ostium primum is much lower. The anterior inferior aspect of the atrial septum, the atrioventricular septal defect, so it's sometimes called atrioventricular septal defect, okay? It only accounts for about 15% of ASD. And again, it's associated with a cleft in the anterior mitral leaflet and mitral regurgitation. So if this is your let's use this. If this is your septum, atrial septum, in the uppermost portion of the septum, it's the sinus venosus type of defect. In the middle is the secundum type of defect. And in the lowermost portion is the ostium primum defect. Sinus venosus, ostium secundum, and then the ostium primum. So the ostium secundum is the most common. Ostium primum only accounts for about 15% of ASD. It is sometimes called an atrioventricular septal defect, and it's associated with a cleft in the anterior mitral leaflet and mitral regurgitation. All right, so you can see that this defect is, I don't know if you guys can see it, but this defect is way down the lowermost portion of the atrial septum. And if you look closely, you can see that the AV valves are on the same plane. Okay? And that is why it's a partial endocardial cushion defect. The endocardial cushion, so these structures sort of form at the same time. The uppermost portion of the ventricular septum, the lowermost portion of the atrial septum, and the AV valve. So when they're in the process of development, so the ventricular septum comes down like that. The atrial septum comes up like that. And then the AV valve comes across, and the other AV valve comes across. So they're supposed to come and fuse. So in the developing fetus, these structures are supposed to come and fuse. So the ventricular septum is supposed to come down, atrial septum is supposed to go up. If this is the tricuspid valve, it's supposed to come across. Mitral valve is supposed to come across. If there's a delay or arrested development, then you can get with a complete endocardial cushion defect. You get a VSD, a ASD. You get a problem with the tricuspid valve and the mitral valve. That's a complete AV canal defect or complete endocardial cushion defect. But if the ventricular septum comes up normal and just the lowermost portion of the atrial septum didn't form properly, then you get the ostium primum and you can get the cleft mitral leaflet. Or you might get some problem with the tricuspid valve. Okay? So this is what it looks like. And when you look here, you see the valves are on the same plane. Okay? Valves are on the same plane. Your tricuspid valve is supposed to be inserted lower in the ventricle than the mitral valve. But with endocardial cushion defect, they're on the same plane. And you can see the atrial septal defect right there, ostium primum. The sinus venosus type of defect is not common, less than 5% of ASD. Okay, it involves the venous outflow of either the superior vena cava or the inferior vena cava. Okay, and the sinus venosus type of ASD is associated with anomalous connection of the right-sided pulmonary veins into the right atrium or superior vena cava. So what we're saying, the sinus venosus type of defect, you commonly get partial anomalous pulmonary veins. That is, the pulmonary veins are going to drain into the right atrium, and usually the superior vena cava. Instead of draining into the left atrium, it drains into the right atrium. And for the diagnosis of sinus venosus type of defect, you usually have to get a transesophageal echo for that. Usually needs a transesophageal echo to make that diagnosis. So again, it's going to be in the uppermost portion. It's associated with anomalous pulmonary vein drainage into the right side, usually superior vena cava. You can have an upper and a lower. Okay. So the atrioventricular septal defect is the same thing as the endocardial cushion defect. And I sort of draw the endocardial cushion to show you how it develops. So if there's arrested development, you can get, if there's total arrested development, then you get an ASD, a VSD, problem with the mitral and the tricuspid valve. So with the endocardial cushion defect, which is an abnormal or inadequate fusion of the superior and inferior endocardial cushions with the mid portion of the atrial septum and the muscular portion of ventricular septum. So So you can get a partial. So partial is usually associated with ostium primum defect. Your AV valves are on the same plane. So this is a tip-off. If the AV valves are on the same plane, and if you have a cleft mitral leaflet, ostium primum defect, this is like a partial endocardial cushion defect. Okay, so the partial atrioventricular septal defect or endocardial cushion defect, ostium primum, because you have a lot of blood going into the right side, your right heart volume overload, or if you get a complete atrioventricular septal defect or a complete endocardial cushion defect, patient will have a ASD, ostium primum, of course, a VSD, a common, what we call a common AV valve, which is abnormal, and regurgitant. So the mitral and the tricuspid valve did not form properly, so they're going to be very regurgitant. The AV valves are going to be on the same plane, and then the patients will develop pulmonary hypertension because you have increased blood flow from the left side into the right side, and then increased blood flow into the pulmonary circuit. That's going to give pulmonary hypertension. So we're going to stop here. So